Hi guys, welcome back. The next topic I want to teach you is bronchial asthma, and this is one of the leading chronic disorders in the world. In fact, 4% of the world population suffers from this disease, and considering such a vast number of percentage suffering from it, they gave an image of this device which is used for self-assessment from the patient's perspective with respect to severity of attack. So they asked what is this device and what is it used for? Well, you guessed it right. This would be called as a peak expiratory flow rate meter, and the logic is that asthma per se is a disorder of expiration. You see, inspiration is an active process. So even if airways are narrowed because of bronchospasm and asthma, well, air can still be going inside, though the amount of air going inside can be relatively lesser. But the point is, inspiration is an active process, so air can still be pushed inside. But expiration is a passive process. If you're going to have a narrowed airway, the air would not be able to go outside, and therefore what we are trying to evaluate in our patient is a peak expiratory flow rate. And if this is critically reduced, it means that the person is having a severe attack, which means that he has to take a medication or have to go and see a doctor. Now, obviously, we have digital versions of the same available, but what I'm trying to teach you is that the patient would be instructed to breathe into this device, that is, breathe out as hard as you can. And when he will breathe out, you can see a cursor here that is supposed to move. Now, suppose this cursor goes all the way up right beyond that green marking that you see. That means that there is nothing to worry. But in case the cursor is hardly moving, or I can say it is just before the red line, that means that the person is having a severe attack, which means that he needs to take a medication. Or if he does not have access to medication, if he does not have access to a puffer or an inhaler at that moment, he need to go and see a doctor so that proper treatment of the case can be done. Peak expiratory flow rate meters are available on various websites. In fact, this is available, the one that I've shown you is available on Amazon. It would be costing hardly 500 rupees, though the digital versions of the same would be costing a little more expensive. Now, because I said that this is primarily a disorder of expiration, so what they have also asked in the exam is one of the important diagnostic criteria for asthma. In fact, in majority of MCQs of the previous, I can say 2 to 3 years, they mainly focused on what I'm going to say next. That is reversibility of airflow obstruction is what we need to demonstrate. And when I'm going to say that, it implies the fact that every time in an asthmatic, when you're going to ask him to blow into a spirometer, you're going to find his forced expiratory volume to be lesser. Because in an asthmatic, the FEV1 value is going to be less. Therefore, I'm going to give this patient 2 puffs of salbutamol and ask him to wait outside the spirometry room for about 15 minutes or so. After 15 minutes, my technician or my orderly will call this patient back into the spirometry room, and we're gonna re-evaluate the patient. We're gonna test his FEV1 once again. And as you know that asthma is gonna have a reversible bronchospasm, so I'm gonna have a FEV1 that will increase. By increase, I don't mean that it will go beyond a normal limit. All I'm trying to say is that the FEV1 will tend to normalize. You see, normally FEV1 values should be something in the range of at least 80% or so. I mean, when we breathe out, we are able to push out as much as about 80% of the air in our lungs can be pushed out in 1 second flat. In an asthmatic, because of bronchospasm, the FEV1 value is lesser. Now it's gonna go towards normal. It may not reach normal, but what they have tried to ask in the exam is that what is the percentage of change that should be seen before giving salbutamol and after giving salbutamol, to say that, okay, I'm dealing with bronchial asthma. Because you see, I have taught another disorder, that COPD. I've talked about emphysema. Guys, emphysema is a non-reversible airflow obstruction because there are bullas and bleps there. Because it is non-reversible, the change of FEV1 that you are going to see before and after salbutamol in emphysema is going to be less than 12%. But for bronchial asthma, you need to demonstrate a percentage FEV1 change of at least 12% to say that, okay, I'm dealing with a case of RAD. In fact, a lot of books, he might not write the word bronchial asthma, he might write RAD, that is reversible airway disorder, though this is a more appropriate term, so I'm writing it on the board. And there's a second definition also. Instead of asking you in percentage, he can also ask you that in absolute amount, how much ml of air should, I mean, the amount of air going out of the lungs, the increment of that air. That increment does not mean that the value is going more than normal. It means it is going towards normal. So your answer would be in absolute value, at least there should be an increment of at least 200 ml of air going out of the lungs. That's the amount of air that was going out of the lungs before giving salbutamol, and the amount of air going out of the lungs after giving salbutamol with a lag period of about 15 minutes. That's to allow the medicine to work. The beta 2 agonists will cause a bronchodilation, and therefore the increment would be absolute in the value of 200 ml. Now, they can also ask you with respect to what would be mild asthma, what is going to be moderate asthma, or what's going to be severe asthma. So, in mild asthma, the FEV1 values, in fact, everything that we're discussing is with respect to forced expiratory volume in 1 second. So, in case you are having FEV1 in the range of about 70 to 80%, we'll say it is a mild attack of asthma. In case it turns out to be moderate, then you will notice the values will be between 40 to 69%. And as far as severe attack of asthma is concerned, the values would be less than 40%. In fact, in the later part, I will even say words like respiratory arrest is imminent. In fact, in earlier times, what I'm writing at the moment was referred as status asthmaticus. But now they do not use the term status asthmaticus, but status asthmaticus basically implies that the respiratory muscles are fatigued. So the guy would obviously be breathing fast, but the breathing will now become shallow. I repeat that again. Breathing will obviously be fast. There would be hyperventilation in asthma. The person will be having accessory muscles of respiration but being used, but gradually these muscles will become tired. There would be an imminent respiratory arrest for which mechanical ventilation would be required. And at this point of time, he will not be able to cooperate most of the time, because when he is going into imminent respiratory arrest, the person would be drowsy, he'll be lethargic, he'll not be able to understand your commands. So this is only for theoretical purposes that they've just put up these gradations saying mild, moderate, and severe. And what I've said at the moment is one of the important diagnostic criteria for bronchial asthma. Majority of questions in the previous couple of sessions have mainly revolved around one asking you about this device, which is used for self-assessment from the patient's perspective, and we'll ask him to keep this device with him handy at all the times in his house. Every time he has an attack, he can see whether he needs to take a medication, does he need to make a call to a doctor. I mean, every time this cursor will move less than, the red marking that I've done. If it does not cross this threshold, it means that a basic call to the doctor has to go. And based on whatever the patient is telling you, or like it's a mother who's telling about her child who's an asthmatic, you can make a decision for them to be called at your hospital for nebulization if required. If they have a nebulizer at home, obviously they can start basic treatment, but in case there is requirement of hydrocortisone injection, then you might have to call the patient to the hospital as well. So in the later part of the discussion, we'll talk about what are you going to do for a severe case of asthma. You will have to give IV steroids, and one of the rationale behind usage of steroids will be that they'll inhibit an enzyme by the name of phospholipase A2. And the advantage of inhibiting phospholipase A2 would be that it will cut down the mediators behind development of asthma. Though we're going to talk about those mediators from the pathology perspective, but as you're aware that leukotrienes, leukotriene B4, leukotriene C4, leukotriene D4, they play an important role with respect to pathogenesis of asthma. So agreed that histamine plays a role. Agreed that there are mast cells degranulation causing release of histamine, but one of the major mediators beyond histamine that they would like to ask you in the exam are going to be cytokines like interleukin 4, interleukin 5, interleukin 13, and then over and above this, I said like leukotrienes play an important role for pathogenesis of asthma. So that's why we'll talk about importance of steroids, importance of inhaled corticosteroids for management of these cases. Now, once I've said that, what I'm going to do in my subsequent slide is that I'm going to say some salient features of the disease which are important from the exam perspective. And then subsequently, we're going to focus on our diagnostics, though I've just given you a heads up with respect to the fact that traditionally in respiratory system, every time we discuss respiratory system, it is HRCT, which is the main investigation. But for bronchial asthma, it is spirometry, because we have to demonstrate the reversibility of airflow obstruction. And having said that, one of the hallmark features for bronchial asthma from pathology perspective, because lots of time nowadays questions are going to be integrated. So he's obviously, he can write that bronchospasm, he can write that reversibility of airflow obstruction as I was explaining to you. But the same thing is written in different way in pathology books. So I'm incorporating that also. That is airway hyperresponsiveness. You will notice that sudden changes in temperature, humidity. Like a person with asthma, if he's sitting in front of an air conditioner, or if he's sleeping in an air conditioner, or if they go to a hill station, or they're exposed to any antigen, that's where the airways tend to contract very fast. So airway, and like for example, cold mountain air, cold mountain air is dry. So even in you and me, when we go to a higher altitude, because there is less oxygen in the environment, it will make us feel breathless. But in an asthmatic, it would be a double problem. One is obviously that oxygen, the amount of concentration of oxygen is breathing is gonna be lesser, but at the same time his airways are gonna constrict in response to the cold air. So airway hyperresponsiveness leading to bronchospasm is one of the hallmark features from pathology perspective. From medicine perspective, what I want to know is, I mean, from a medicine perspective, we evaluate symptoms. Symptoms have to be measurable, or any parameter, any laboratory report has to be measurable. So that is what I told you from the measurable perspective of that increment of 12% before and after giving salbutamol. But from a pathology perspective, you need to remember about airway hyperresponsiveness. Another feature that you always see with asthma is that attacks of asthma are episodic. You will always have episodic airway obstruction. I mean, every time he's going to be exposed to pollution, or there's going to be exposure to cat fur or pollen grains, or any antigenic exposure can contribute to something. Sometimes it can be something as which you and me may not mind, that is the faint smell of lacquer, like the lacquer that is done on furniture. Some people are not able to tolerate that smell, and they tend to develop an attack of asthma as well. So that's why I've written episodic airway obstruction, and this would be associated with airway inflammation. Now, this airway inflammation will explain why we read about excessive mucus production in asthmatics in pathology, and I'll teach you also regarding Cushman spirals. So the features that I've written once again are identical in a sense that the spirit is still the same. Asthma is a disorder of expiration. There's going to be a bronchospasm present, but to make it sound jazzy, the pathologist want to use terms like airway hyperresponsiveness, which would be answered as a hallmark pathological feature, along with episodicity, along with airway inflammation. And apart and over the above this, I would also like to say that asthmatics would be having an increase in the thickness, airway thickness, that is the basement membrane related to the alveoli would become relatively more thickened. And because of this, the thought process of ours would be that because the airway thickness is more and the basement membrane thickness is also more, so if you're going to do a test by the name of DLCO, that is diffusion capacity of the lung for carbon monoxide, this DLCO should become lesser. But look at the data that I'm teaching you, and this is a question that is always asked in the exam and asked to me by students as well. The doctor, you told us that there is increased thickness of the airway in an asthmatic, the basement membrane of the airway is more thickened, there is subepithelial basement membrane collagen deposition. So logically speaking, the DLCO, the diffusion capacity should be less. So I agree to that fact that, okay, the thickness part is more and therefore the diffusion capacity should be less. But I would like to counter this. I would like to counter this by telling you that in asthmatics, there is a second thing that we find, which is that there is also presence of airway vascularization. That means the number of blood vessels surrounding the alveoli also tend to increase. And because of the fact that there is increased larger number of capillaries, the total number of surface area around the alveoli is relatively more. So the diffusion of carbon monoxide would be relatively better. It sounds very paradoxical to say this, but this is how it is, guys. Let me just draw this line diagram. I'll erase it after drawing it just for understanding purposes. We have alveoli and we have limited number of blood vessels around our alveoli, because of which gas exchange will be occurring. Now, suppose, just for discussion's sake, if you take this red to be representation of fibrosis, then if there is going to be collagen here or fibrosis here, then the diffusion, because it's going to act like a barrier, like in idiopathic pulmonary fibrosis, interstitial lung disease, we have substantial amount of fibrosis, so the diffusion part should reduce. Agreed. But at the same time, what he's saying is that fine, I mean that subepithelial basement membrane thickness is increased, but at the same time he says that because there is airway inflammation, plus there is, inflammation would cause these blood vessels to be relatively dilated, and the number of blood vessels is also more. So because of this increased airway vascularization because there is more surface area available for gas exchange. I mean, you can see, I mean, after all, the gas has to diffuse. Now, here the chances of gas, or mathematically speaking, the probability of diffusion of gas would be relatively more. So the final output is, guys, I've tried to give justification of this fact. I'm erasing this because this diagram would not make any importance from the perspective of solving an MCQ. It was just for understanding purposes, that ultimately larger number of capillaries, larger surface area available for gas transport, and therefore the DLCO part would be increased. In fact, I would like you to listen to this DLCO part in a separate video that I have taken care of, though this is pure hardcore physiology, guys, but I've described DLCO as a topic even in the pulmonology section, where I've talked about alveolar arterial gradient and the types of respiratory failure. The bottom line is DLCO is increased in congestive heart failure. Again, in congestive heart failure, what happens is not the number of blood vessels is more. Here I showed you number of blood vessels is more. In congestive heart failure, it is rather gonna be that the blood vessels are gonna be more dilated. They're gonna be having more hemoglobin inside them. They're gonna be having more blood inside them. Overall, I can say more blood inside them, more hemoglobin inside them, and therefore the chances of diffusion would be relatively more. So let's just make a quick recall of those conditions where DLCO is thought to be increased. That's gonna be congestive heart failure. Then is going to be polycythemia. Polycythemia is the easiest one of these to understand. I mean, when I say polycythemia, everybody is like, okay, sir, hemoglobin is more, so it will bind to more oxygen, more carbon monoxide, understandable. But in congestive heart failure, the rationale or logic I gave you, dilated blood vessels. Dilated blood vessels implies more amount of blood present there. And in asthma, I said it is more number of blood vessels, right? There's a difference between the two. In heart failure, I said dilated blood vessel there. In asthma, I said blood vessels number is same, but the blood vessel caliber is same, but the number of blood vessels is more. Airway vascularization is improved in asthma. This is a pathological domain which I would like you to remember. And then another condition where we read about increased DLCO is where there is destruction of the basement membrane. I mean, that is again easy to remember. Good pasture and polycythemia, nobody has an issue. I mean, good pasture because basement membrane is destroyed, so less barriers across transport of oxygen. Polycythemia, more hemoglobin. But in heart failure, I repeat that again, dilated blood vessels, so again more surface area. And in asthma, the vascularization part, the number of blood vessels is more, which is why the DLCO part is increased, and that is why I've invested some time into explaining this aspect before you. Another feature which I would like to tell you is from the blood gas perspective, that every time you have an exacerbation of asthma, the person is going to hyperventilate, and this hyperventilation will contribute to wash out of carbon dioxide, and therefore asthmatics would be having respiratory alkalosis. Now, in case I change it to severe acute exacerbation, then obviously the severity of hypoxia will be even worse off because there is more severe bronchospasm, so less air is going inside, so the severity of hypoxia will become more, and therefore initially patient will have anxiety, then he will become agitated. I mean, hypoxia makes a person become angry, so you will notice agitation on the face of a patient, and you will, if you quiz him, if you ask him again and again, how are you feeling, he might get irritated. And at this point of time, guys, the muscles are beginning to get tired. Because the muscles are beginning to get tired, so therefore they will not be able to do a effective ventilation, and gradually you will see CO2 is coming back to normal. That CO2 coming back to normal is not good news, it is bad news. It tells you that the person is deteriorating. I'll repeat that again. Like you and me can hyperventilate. If I'm having an acute asthma attack, if I'm hyperventilating, I will be having less carbon dioxide in my body because of carbon dioxide washout. But because the muscles are getting tired, that implies that gradually the body will not be able to do a effective clearance of carbon dioxide. If I'm not able to do a effective clearance of carbon dioxide, the CO2 values will tend to come towards normal. And when the same patient will tend to go into what is coming next, that is impending respiratory failure or impending respiratory imminent, he might write the word either imminent respiratory arrest, or he might write words like impending respiratory failure. I mean, both imply the same. The point is that the person now will start having a buildup of carbon dioxide, guys. That is really, really dangerous, because this is the time when you might be able to notice asterixis in a patient. Plus, there would be stupor and drowsiness because there would be development of carbon dioxide narcosis. If an asthmatic is sleeping comfortably, that is always a cause of concern. Asthma patient, if he is anxious, If he's doing this hand signal, like, I'm not getting breath, and he's trying to signal to you, sir, like, you ask him, how are you feeling? And most patients of severe acute asthma, they are like, they're gonna shake their head and they're gonna try and communicate to you that they are not able to breathe properly. And in case it deteriorates into a imminent respiratory failure or imminent respiratory arrest, then in those circumstances, then you will notice the same patient, he would be lying without giving you any answer. Extreme drowsiness will be noticed, and person will start going towards respiratory acidosis. In fact, that is the standard presentation of all lung diseases. We saw that in COVID time also. When patients used to come to us, they used to have respiratory alkalosis. Then as they deteriorated, the CO2 used to tend to come towards normal, and towards the terminal part, like patient of COVID in Delta, due to Delta strain, if he did not get hospital admission, people died in their cars at COVID time, waiting for hospital admission outside the casualty of a hospital. So when the person was dying, then because he was having respiratory failure, because he was having the muscles of respiration were tired, respiratory fatigue was present, that is when the carbon dioxide value was getting elevated, and that is when they were progressing into respiratory acidosis. So there are a couple of pointers which I just want to say at the moment once again. That would be from a pathological perspective, we have hyperresponsiveness of the airway. Attacks of asthma are episodic. There is a airway inflammation that is present. And I would like to just correlate this with the Robbins, from the Robbins perspective, like you will read about Crayola bodies, or you will read about, I'll jot it down subsequently also, but I think you can recall from pathology, terms like Cushman spirals, Crayola bodies, charcot Leyden crystals. There are a couple of pathological terms that they always, teach you whenever you are reading Robbins. And I have described them, in fact, but in a different way. The terminologies being hyperresponsiveness, episodicity, and airway inflammation. And out of these 4 points that I have currently highlighted, I would like to say the most important one from the clinical perspective to demonstrate that, okay, I'm dealing with bronchial asthma, which is a reversible airway disorder, versus emphysema, which is non-reversible, would be that I need to demonstrate this mathematical change in the value of FEV1. Now, a few more words from the pathophysiology perspective of the disease, because you will read that terms written like type 2 inflammation or non-type 2 inflammation. So let's look at what do you mean by type 2 inflammation. Type 2 inflammation would mean that the cytokines which are involved here would be interleukin 4, interleukin 5, and interleukin 13. And I'm going to teach you drugs also subsequently that we will be using to neutralize it. Like, for example, for interleukin 5, we'll be talking about mepolizumab, or there are a couple of drugs which can block the interleukin 5 receptor also. So subsequently, I'm going to talk about biologicals. I'm going to talk about monoclonal antibodies, which can be used in asthma cases where, in spite of using maximum dosages of high dose inhaled corticosteroids, plus long-acting beta-2 agonist, plus even oral steroids have been used. You've exhausted all your firepower. All the traditional drugs like inhaled steroids, maximum dosage, maximum dose of LABA, maximum dose of oral glucocorticoids have been used, and still you are having attacks. That's when the importance of biologicals would come in, and we'll talk about monoclonal antibodies, which would be useful for management of these patients. Then they can also ask you which cells would be responsible from type 2. I think you would have guessed it anyway. Your answer would be Th2 type of cells, that is Th2 subset of CD4 helper cells. Other cells which anyway play a role are easier ones to understand. That would be mast cells, eosinophils. And in asthmatics, whenever you get absolute eosinophil count done, sometimes eosinophil count will be normal, but in some cases it would be elevated. If it is elevated, it is type 2 inflammation, and this would be amenable to administration of steroids. But a lot of cases might be having non-type 2 inflammation where inhaled corticosteroids would not be working. So he can also ask you with respect to the mediators, which of the following would be involved with pathogenesis of non-type 2 inflammation in an asthmatic, and answer would be interleukin 6, and then would be TGF beta. And apart from this, he can ask you what are the cells which would be involved there. So let's just compare the cells. Earlier I was saying Th2 type of cells, now I'm saying Th1, Th17, and neutrophils. Let's do a quick recap here. Asthma, you will notice in earlier times was written like atopic and non-atopic asthma, intrinsic and extrinsic asthma. Now they do not use those terms. The terms are older, guys. Earlier books used to say intrinsic asthma, extrinsic asthma. Now the terms are not used. Now from the pathophysiology perspective, we call it type 2 inflammation, or we say non-type 2 inflammation. And the reason for this would be because of the inflammatory cells that we're talking about. and we're talking about cytokines which are present here. And the importance of studying this information is that we have been able to develop drugs which would be able to counteract or counterbalance the impact of interleukin 13 or interleukin 4 or interleukin 5. And by using these drugs, we'll be able to reduce severity of attacks by as much as 50%. I mean, those asthmatics where even oral glucocorticosteroids are not working, earlier we did not have anything for them. But in the treatment part, I'm going to focus on drugs, and we're going to talk about these molecules, what are the indications for management of them. But I've just tried to give you a heads up with respect to that which category of asthma will be mainly responding to inhaled corticosteroids. That would be mainly type 2 inflammation, whereas non-type 2 inflammation usually is not going to respond to administration of steroids. From the perspective of smooth muscles, as I've explained to you, smooth muscles will be hyper-responsive, and along with this hyper-responsiveness, you also need to remember that the smooth muscles would be having both hyperplasia as well as hypertrophy. So there are 3 H's I said for smooth muscles, that is hyper-responsive airways, written already on the first slide, hyperplasia and hypertrophy. The basement membrane is thickened, as I've explained. Though the basement membrane, this is itself a question, guys. A lot of guys neglect this fact. They think that asthma would be having normal airway thickness or decreased airway thickness. No, it has increased thickness of the airway. But in spite of that, as I've explained to you, the airway vascularization part is more. The airway inflammation part is also more. And we have specialized tests also. Like one of the specialized tests that I'm going to be teaching you for airway inflammation is FeNO. Traditionally, we read about, FeNA, F-E-N-A. That's with respect to renal failure. No, FeNA less than 1%, more than 1% is with respect to renal failure. So we read FeV1 for asthma, we read FeNA for renal failure, but I'm going to teach you FeNO, that is fractional excretion of nitric oxide, because nitric oxide levels in the expired breath is increased because of airway inflammation. Though this FeNO test may not be available at routine centers, but yeah, that's one of the specialized tests that can be used for assessment of asthma patients, especially in those cases where there are borderline findings from the spirometry perspective, like the values are not reaching up to 12% or just around about 12%, then specialized testing would also be required. And airway inflammation can be indirectly measured. It's everything from our clinical perspective should be measurable. So airway inflammation is measured by a FeNO test that would come up in the workup. As I said, asthmatics would be having excess mucus production. And along with this mucus production, there's one more problem going on, that is epithelial denudation as well. And therefore, he's going to correlate these facts with Robin's pathology. Though I have mentioned those terms already, just a quick recap. One, you are always going to read about what is called as Kurzman spirals. Now, what do you mean by Kurzman spirals? Well, spiral word is itself understandable, but just to put the data in the right perspective, Kurzman spiral would mean that these are mucus plugs that would be, especially if you have seen an asthmatic after he has taken nebulization. They cough it out, and when he'll cough it out, that would be very sticky sputum that he may show you on a tissue paper or on a handkerchief you've seen. That would be that whitish mucus plug, which is what is called as Kurzman spiral. The second one that I described can be asked again, because it is written as crystal charcot laden crystal. So there are 2 reasons why it can be asked charcot laden crystal. One is for its particular shape, and that would be a bipyramidal shape. I mean, charcot laden crystals would be what? They would be eosinophilic protein. And this eosinophils are one of the important cells that mediate bronchial asthma, especially type 2 inflammation. And this eosinophilic protein, the crystal shape would be bipyramidal. I mean, usually we read about crystals and their shapes with respect to kidney stones, but today I'm teaching you bipyramidal crystal shape with respect to eosinophilic protein, which would be on microscopic examination of a asthmatic sputum, and he's producing this sputum, or he's showing you this sputum after you have given him nebulization. Because initially this sticky mucus is going to occlude the airway, but the moment you're going to dilate the airway, that's when the airflow will improve and an asthmatic would be able to cough better. Most of the time asthmatics, you will see they'll complain of the shortness of breath and the tightness in the chest. But once you give nebulization, or if they're using a puffer, the airways tend to open up. And then when they're able to effectively cough, that's when you have that sputum plug available. When you check it under a microscope, you would be able to see these eosinophilic proteins, which are bipyramidal crystals. And then the third feature, which again begins with a C, is what is called as Crayola bodies. And what is a Crayola body? That would be epithelial denudation. As I said, I mean, there is a sloughing respiratory epithelium. The epithelium of the airways would be a pseudo-stratified columnar ciliated epithelium, and this sloughed respiratory epithelium is coming out in the sputum of the patient. So I can say that this slide is the upper part of the slide and the lower part of the slide is saying the same thing. It is just that a specific names have been given. So I thought I should also just make you revise these names as well before we get into how the case would present. And then subsequently, we're going to talk about what are the drugs that we'll be using. And at this moment, I just want to make it very clear to you that if they say what is for management, what drug is recommended for acute exacerbation of asthma, then do not answer SABA. Do not answer salbutamol. Guys, that's old information. The updated information is that for any asthma patient, you have to give, reliever, you have to give a controller medication. But if you want to manage a case effectively, don't use alone SABA. They've documented that if you keep on giving SABA again and again and again, one, there is problem with tachyphylaxis. They would be developed a tolerance. Alone SABA causes rather the airway inflammation to continuously worsen because you're not treating the root of the problem. You see, the root of the problem is this airway inflammation that we're talking about. We need to control that. And for that, you need inhaled corticosteroids. So for asthma management, we need to give inhaled corticosteroids with LABA. And currently, it is discouraged to use SABA alone. He says, if you do not have anything, okay, you can use salbutamol. See, he's saying a point. Listen to that carefully. Salbutamol may be used, but alone SABA repeatedly used increases mortality. Looks surprising, no? Asthma is all about salbutamol. I mean, the first drug that we study, and we anticipate that if we're giving salbutamol, it should be decreasing mortality. But I'm teaching a very specific information which is relevant for you guys from the update perspective, which is that alone SABA in repeated usage of SABA alone without taking care of the inflammation of the airways is going to cause rather increased chances of mortality. So how do you manage a case? Even if a person is coming with sudden onset breathlessness, you're going to use a LABA, and along with LABA, you're going to use inhaled corticosteroids, which would help in tiding over all these aspects with respect to airway inflammation that I have explained to you. Now, quick look at the triggers that could be responsible for development of an asthma attack. Allergens or irritants. One can be simple house dust, or it could be mites. It could be exposure to pet fur. Like lots of time we'll advise these patients not to keep pets in their houses because the pet fur, the hair that falls off from a cat's body or a dog's body could also act as a trigger and could contribute to deterioration. Apart from this, even indoor fungi. So the list is obviously extensive. We need to figure out what is the trigger behind it, and we need to mitigate or reduce the exposure of the person to that antigen, because otherwise the attacks will continue. Because as I said, asthma has a episodicity. It is episodic attack, so we need to minimize the exposure to the same. Then at the same time, exposure to viral infection, studies have shown that respiratory syncytial virus and rhinovirus exposure, especially in infancy, is associated with increased incidence of asthma in subsequent age group. Then exercise and cold air, because I said cold air will cause airway hyperreactivity, hyperresponsiveness, and will trigger a bronchospasm. You will notice that every time there is smog in North India, and now this time smog has been present all over India, because of that El Nino effect. But the point is, air pollution plays an important role, and it is carbon monoxide, then is nitric oxide, and then would be sulfur dioxide. Sulfur dioxide is mainly present in diesel fumes, and that is why, the switch to electronic vehicles or electric vehicles is being recommended. Then he would love to ask you about drug-induced asthma, and one of the important ones is going to be non-selective beta blocker, that is propranolol. Over and above non-selective beta blocker, even ophthalmological preparations, like timolol eye drops, even ophthal preparations have been shown to trigger an asthma attack. And then he would love to ask about aspirin as well. So I'm going to talk about aspirin desensitization and interventions for aspirin-induced asthma. But every time you're going to purchase a strip of, aspirin, it's always going to say may trigger asthma attack in susceptible individuals. So COX-1 inhibitors per se, that is aspirin, then timolol, propranolol. These are list of drugs which can trigger DIA, that is drug-induced asthma. They can ask you about occupational exposure. He can ask you in which occupation there is highest chances of development of asthma. Then it is the cleaning staff, whether it is cleaning staff of our hospital or the cleaning staff of the municipal corporation like MCD in Delhi, right? So the cleaning staff of MCD of Delhi would be having highest incidence of development of bronchial asthma. And the second entry that is made is very surprising. He said nursing staff. So cleaning and nursing are two occupations. In fact, he said 10 to 25%. Listen to the data. 10 to 25% of asthmatics might be having an occupational exposure to antigens. And he said listed two professions there, cleaning and nursing staff, who would be having higher incidence of asthma apart from hormonal changes in pregnancy. And then you will also notice a age-wise shift in the incidence. In fact, this age-wise shift in the incidence is very, very, I would say, interesting to note. So I would like to use a different color to highlight this. You will notice that when the age of the patient is less than 20 years, then asthma is more in boys as compared to girls. But then you will start noticing a shift after 40 years of age. Majority of cases that come to you are going to be female patients. I repeat that again, the shift happening, because traditionally in a disease, no, either it's male or female ratio, male will be more or female will be more. But here I'm teaching you a shift happening, that at a younger age group, it's boys who tend to have more asthma incidents. But when it comes to age group changing beyond 40 years of age, it's mainly female patients who will be coming to you. And now let us focus on the diagnosis and the workup. So the case would come to us with recurrent wheezing, there would be shortness of breath, cough on exposure to irritants, and the symptoms would be worse mostly at night time. I mean, most of the time, asthma attacks are nocturnal. Now, the logic for that, all I can say is that at night time, the temperature is lower as compared to the daytime. So colder air, as I said, can contribute to airway, can trigger bronchospasm, and asthmatics have hyperresponsive airways. So most of the time when asthmatics would be coming to you, either the mother, like if the child is asthmatic, is telling you that child did not sleep the whole night and he was setting up because he was feeling uncomfortable or lying supine, as you will notice in most asthmatics. And if he's not gonna sleep the whole night, well, he's not gonna get up for school in the morning. And maybe the mother was also tired and they got up late, the alarms kept on ringing, and she says like the absenteeism of the child in the school has increased substantially, to the level that the principal has specially called the teacher, saying that your child is not attending school regularly, get a medical certificate, etc., so that we might deregister or deroster your child as well. So most of the time you will notice that the attacks would be occurring either on awakening, because even at early morning, 5:30, 6 a.m., it's going to be relatively colder as compared to the remaining part of the day. So in some cases, it's going to be nocturnal attacks, which will prevent the child or adult from sleeping. And therefore, in the goals of therapy, I'll be teaching you that our main objective would be that asthmatic should be able to lead a normal life. A normal life, I mean, be able to get a normal sleep as well. Because if an asthmatic is awakening multiple times per night, then the person might have absenteeism from work. So the logic behind, as I explained, I mean, why it is mainly nighttime is one, related to bronchial tone. Bronchial tone is more at night. Bronchospasm is obviously the exaggerated version of that bronchial tone, which is increased. But the point is, bronchial tone is more at night, and then the cold air adds as insult to the injury, and the airway hyperreactivity results in attacks being mainly nocturnal. Plus, you will also notice every time asthmatics are exposed to sudden change in temperature, like they go to hill station, or if the AC is switched on at night and at 16 degrees Celsius they continue sleeping, obviously with a blanket on, but they'll start getting an attack. So most of the time, nighttime on awakening or sudden change in temperature and humidity are the usual causes. Then another fact from the clinical perspective, what you need to see is that lots of time there could be comorbidities present, due to which you will notice that there would be poor response to even moderate dosage of inhaled corticosteroids. Like you are giving moderate to high dose of ICS and LABA, and still there is presence of an attack. So what are those comorbidities which are responsible? One of them is GERD. The logic is that microaspiration of stomach acid causes development of reactive airway disease. The second reason could be OSA, that is obstructive sleep apnea. So these comorbidities, because see, increasing the dose of drugs in this case is not going to be the only solution. If I fail to pick this up, what will I do? I'll keep on upgrading the medication. That is, I will switch him over to high dose inhaled corticosteroid, then I'll start giving oral corticosteroid, then I'll start having side effects of oral corticoids, and then I'll say, okay, fine, now we will switch you over to mepolizumab or dupilumab or omalizumab, and those molecules are expensive. You are unnecessarily producing economic burden on the case. Why? If you as a doctor fail to recognize the comorbidities, and this is important from MCQ perspective as well, though, I mean, he'll say which are the important comorbidities related with bronchial asthma. There are two of them, though, I mean, there's a huge list. They are the common ones that I've told you: gastroesophageal reflux disease and obstructive sleep apnea, two important ones. Over and above this, you also need to assess patient for concomitant presence of nasal polyps. You will notice a large number of asthmatics would be having concomitant allergic rhinitis as well. So you will notice that in allergic rhinitis, the nasal mucosa, like if you send him to a ENT consult or if you evaluate by yourself, the nasal mucosa would be relatively pale. And then you will also assess for drug intake. As I've explained on the previous slide, that drug intake would mean that you will be taking history with respect to, do you take ACE inhibitors? If you are hypertensive, then ACE inhibitors anyway contribute to cough. One of the reasons for nocturnal cough can not only be asthma. Reason for nocturnal cough, I mean, there are multiple reasons for nocturnal cough. In fact, I can just jot it down. I mean, one of the important reasons why a person is sleeping at night and is having nocturnal cough could be GERD, gastroesophageal reflux disease. Yes, guys, microaspiration of acid can contribute to this. Then is bronchial asthma that we're discussing at the moment. Then nocturnal cough could be due to PND, that is post-nasal drip. PND that I'm talking about at the moment is not paroxysmal nocturnal dyspnea, but is a post-nasal drip. Like this guy could have had adenoid infection or he could have a sinusitis, and therefore it's important to send these patients for a ENT consult. And ACE inhibitors anyway, they contribute to cough. I mean, they contribute to dry cough. My point is not that ACE inhibitor will cause nocturnal cough. They can contribute to dry cough. So while assessing and saying that, okay, I'm dealing with asthma, it should not happen. No, that he's taking ACE inhibitor and that is causing cough. And I'm thinking that it is asthma which is causing this guy to suffer from cough. Other intake that must be considered is propranolol. Lots of time propranolol might be used for prophylaxis of migraine. In fact, one of the major drugs that used in prophylaxis of migraine, I've taught that in neurology, is propranolol. Along with that, we have multiple other drugs also available. Then patient could be having open angle glaucoma. For open angle glaucoma, he might be taking timolol, and this timolol preparation might be causing it, or he's taking aspirin for some cardiovascular reason. And therefore, these are a couple of triggers which have to be considered, or drug intake, which could be responsible for development of an asthma attack. And most patients are going to be well between the attacks. It's only during the attack that he's going to suffer. So in a while, I'm going to explain to you that how, as a doctor, would you evaluate whether the case is having mild asthma, or is having severe asthma, or is having an imminent respiratory arrest. For that, I'll discuss on the subsequent slide. But at the moment, I just wanted to sensitize you to one, the comorbidity component, and what are the things that you should keep in your mind from assessment of a patient. That could be for concomitant allergic rhinitis, and assessment with respect to intake of a couple of drugs which could cause DIA, that is drug-induced asthma. The main investigation for diagnosis of this condition is spirometry. And in spirometry, what are you going to check for? You're going to check for FEV1. The cutoffs for mild, moderate, and severe, I have already explained to you. I've already told you that we can either be evaluating peak expiratory flow rate, or we can be checking FEV1. I mean, peak expiratory flow rate would be a much more cruder method as compared to FEV1. And then in spirometry report, he will also mention regarding FEV1 FVC ratio. As has been explained to you, every time it is obstructive airway disorder. This is itself a question. In obstructive airway disorder, what will happen to FEV1 FVC ratio? It would be reduced, whereas when it comes to restrictive airway disorder, this ratio will usually be normal or will be more than 0.8. I repeat that again. In all obstructive airway disorders, whether it's going to be emphysema, COPD, chronic bronchitis, or asthma, FEV1 FVC ratio would be less than 0.7. In restrictive airway disorders, the values would be usually given in value of more than 0.8. Then we can also assess the flow volume curve. I've described flow volume curves separately, but at the moment I'm just trying to hand draw that once again for you. You will notice that in flow volume curve, on the y-axis, inferiorly would be inspiration and superiorly would be expiration. And in an asthmatic, what you're going to find is that the inspiratory part is going to be fine, but then you're going to notice a scalloping. You can notice a concavity. You can either call it a concavity, or like traditionally in the books, it might be written as a scalloping. And this scalloping part will also become less on giving bronchodilator. What I mean by becoming lesser would be that if I am gonna evaluate my patient after giving salbutamol, this curvature, this scalloping part would become less, and this change that you can see in the curvature or the area under the curve is what I was trying to explain to you earlier. From a mathematical perspective, is an increment of approximately 12% or 200 ml of air, which is one of the common features that has been described. Then you will also notice that asthmatics will be having worsening of attacks at night time because of lowered temperatures. So the diurnal variation would be present. This diurnal variation in peak expiratory flow rate can be as much as more than 20%. The main criteria to be remembered is the 12% value that I've already explained to you in the starting of this slide. I'll just jot it down once again. The FEV1 originally in the patient is less. And then you are going to give salbutamol. You're going to wait for 15 minutes. You're going to call in the patient once again. And when you reevaluate, the FEV1 will increase. By increase, I do not mean that it will increase more than normal. It will tend to normalize. And this percentage of change has been explained to you already, because they love to ask you this mathematical data. So I have said that if suppose in the MCQ both these datas are given, 20% also and 12% also, which one would you select? Obviously that 20% data is for peak expiratory flow rate, and the 12% that I told you is for FEV1. You will be selecting what I put as 2 marks here, change of FEV1 as told to you in the initial slide, but 12% is one of the main diagnostic criteria. Then when we will check the total lung capacity is normally 6 liters in an asthmatic, because there is air trapping. Air trapping is because there's a narrowing of the airway, so air can't be pushed out, and because residual volume is increased in asthmatic during an exacerbation, so therefore total lung capacity will also be answered by you as increased. Now listen to my statement once again. Asthmatic, when he's having an attack, that's when there is air trapping. When he's taking medicine, if he's compliant with medicine, there is no air trapping. So you will notice in some books written TLC is normal in asthmatics, and I get a query, sir, you told us TLC is more, in book it is written normal. Why that is written normal? Because if he's between an exacerbation, when he's asymptomatic, TLC would be normal. Asthmatic can be playing football. Asthmatic, you might be having asthmatic friend who could be playing football with you, but when he is having an attack, he would not be able to run as fast as you. So the message is, during an attack, TLC would be answered as elevated. Otherwise, routinely between attacks, TLC values would be normal. Now, apart from evaluating these parameters, there is one more test that is written in the textbooks that is called as methacholine. You can understand that methacholine would be a cholinergic compound, and smooth muscles respond to acetylcholine. So there's another one that's called as methacholine challenge test, in which we are going to give a cholinergic compound and it's going to cause a drop in FEV1. The drop in FEV1 with methacholine challenge would be something in the range of about 20% or more, and this could also be written in a question. So now you are having 3 data. One is the change of FEV1 diurnal variation of more than 20%, FEV1 increasing up by 12%, and then is a FEV1 decrease by 20%. These would be like, while he'll write these terms in the MCQs is because he wants to fox you, and this is the reason why I write in the beginning itself. I focused on this particular statement of mine right in the beginning, because otherwise if I would have told you so many values and so many definitions to remember, the query of most people is, sir, you were telling us 3 definitions, which one should you remember? I just highlighted that before you. All of these are useful for diagnosis of asthma, but the one with the maximum importance is the one which is most frequently asked, methacholine challenge test. And then apart from this, unofficially I can add that they have also used mannitol, though there is no standardization, but methacholine challenge, mannitol is given to these patients via nebulization, or instead of mannitol, they have also used hypertonic saline. I'm putting a line over this to say that there is no standardization for these tests. But mannitol and 3% saline, and don't try to do that in your patient. It's only for academic reasons that I'm telling you that mannitol and 3% saline has also caused a substantial decrease in FEV1. So these are again provocative tests which are described in a textbook. Then we focus on eosinophil count. Always get a absolute eosinophil count done. If a person is having type 2 inflammation, then it's okay. Eosinophil count would be turning out to be normal. But in some cases, the values would be usually in excess of 300 cells per microliter. In case you get a report of more than 300 cells per microliter, it means that your patient is ready for targeted treatment. He is ready for inhaled corticosteroids. In fact, this eosinophil count, values more than 300 correlate with the severity. And this also tells you that your patient should be responding to management with most of the time inhaled corticosteroids. God forbid, if he has a very severe exacerbation, then you can be using even oral glucocorticoids. At this junction, I would also like to tell you, I'm going to write it and erase it because the next statement that I'll say will come towards the end of this video. In case you're reading a question in which eosinophil count is given to be, substantially elevated, and along with that, he's also mentioning elevated immunoglobulin E values. Now we know that asthma is a inflammatory disorder, so that is okay. But in some questions, he might give you outrageously high values of immunoglobulin E. Let me just jot it down. I said in an asthmatic, eosinophil count can be elevated, immunoglobulin E can be elevated. But suppose in a question, he says immunoglobulin E values are more than 1000 international units per ml, and he also says words like brownish sputum plugs in an asthmatic. Now, I have not described any brownish sputum plugs, but if a question says asthmatic is having brownish sputum plugs, plus is mentioning immunoglobulin E elevation more than 1000 international units per ml, plus he says central bronchiectasis, then you must think of a condition called as ABPA, allergic bronchopulmonary aspergilloma. Allergic bronchopulmonary aspergilloma will come towards the end of this video. If you scroll through that list of the notes that comes to you in the app or in the printed version, you will see ABPA given in the end. But I just given you a heads up that what is the importance of reading that report in case you get outrageously high values. This is being erased at the moment. Why? Because this is as discussed towards the end of this video. But I wanted to give you a heads up in case you get a question where grossly elevated IgE values, 1000 international unit is given, plus he adds words like brownish sputum plugs in an asthmatic, then it's like, kuch to gadbad hai. And that gadbad is that he's talking about a colonization of the airways by aspergillus species, and it's called as allergic bronchopulmonary aspergilloma. How to manage that will also be taught to you towards the end of this video. And over and above this, if you're gonna do an X-ray in an asthmatic between attacks, it is gonna be perfectly normal. But if you're gonna do an X-ray during an attack, you might be getting hyperinflation. You might be able to see flattening of the diaphragms because of the trapping of the air. So the beauty of medication is that the asthma attack between attacks, the chest X-ray is gonna be perfectly normal, and it's only during an attack that you might be able to detect an abnormality. This is again important. Why? Because as I was teaching, suppose a question is mentioning asthmatic patient with central bronchiectasis. Then the moment, this word, guys, you're not gonna read anywhere else in medical literature, the word central bronchiectasis. Every time in your brain, it should ring a bell that this is gonna be talking about ABPA, that is allergic bronchopulmonary aspergilloma. So in these slides, I've tried to tell you what should you be suspecting. What are you gonna get with respect to asthma? What are the comorbidities? What you should ask with respect to drug intake, and then more importantly, what should you do if a person is complaining to you only with nocturnal cough? What are the differential diagnoses to be considered? And then order up spirometry, and that would do the trick and help you in diagnosing your patient. Having said that, if an asthmatic patient is able to tell me that, sir, I'm not able to get breath, if he can talk to me by saying these words, I'm not able to breathe properly, if he can talk in sentences, it would imply that he is having a mild attack. But suppose an asthmatic patient is not able to say these words, I am not okay. He's maybe speaking slowly, I am, and he's hyperventilating, not okay. Or he's just shaking his head like this, or might be saying, like you asked him, what's the problem? And he's not even able to say that I'm breathless. He'll just shake his head and then he'll try to act with his hand that I'm not getting enough breath. So if a person is gonna talk to you in monosyllables, if he's gonna talk to you in like yes or no or in words, that means that he's having a severe attack. And in case it is an imminent respiratory arrest, then person will be totally silent. He's not gonna give you any answer because at this moment, mostly patient will be drowsy. As I mentioned, if it is a mild attack with respect to the alertness, you might be noticing anxiety on the face of a patient. Agitation may or may not be there, but when it comes to a severe attack, a visible agitation on the face of a patient can be seen. He's trying to tell you, he would try to touch your hand and say, sir, I'm not getting breath. Our patient normally will communicate. But here, the amount of breathlessness is so high that because he's not getting any breath, you will notice that he's sitting up in the hospital bed. If an asthmatic can lie down, he's fine. If he's sitting up, he's touching you and he's trying to do like this, that I'm not getting breath, severe agitation, that would mean severe acute asthma. And in case an asthmatic is drowsy, if he's not alert to the surroundings, normally, like, let me say, let's take about a child. When a child was brought to my hospital, he was crying, but now he's drowsy or he's very sleepy, and mother is saying, yeah, he's sleeping, sir, he did not sleep the whole night. It's a cause of concern. An asthmatic patient should be up and should be troubling you. If he's going to be lying down peacefully, that means things are wrong. Then as far as body position is concerned, as I explained to you, if an asthmatic can lie down comfortably, it's okay. But if it is going to be patient is sitting up with the remaining features that I've explained to you, then this would be a severe attack of asthma. And in case it is imminent respiratory arrest, then patient would be unable to recline. Even if you give him a hospital bed in which he can recline, it would not be possible. Plus the wheezing part would also dramatically change. In mild asthma, a mother might be telling you that I can hear some sound from the chest of the child, because child's chest would be thinner, chest wall is thinner, so you might be able to hear a wheeze, audible wheeze. Otherwise, I can say loud rhonchi, and this loud rhonchi will mainly be present in the phase of expiration. But when it comes to severe, these would be very loud rhonchi, and these very loud rhonchi that I am currently describing before you would be present both in the phase of inspiration as well as in expiration. But in case the rhonchi become completely disappeared, earlier we used to say silent chest, we used to say status asthmaticus, but now I'm trying to tell you that if the chest is totally silent and the patient is also very silent, it means that he is going into imminent respiratory arrest. Then as far as FEV1 values are concerned, you will notice FEV1 values in mild will be usually in the range of 70 to 80%. If it is severe, it would usually be less than 40%. If it is imminent respiratory arrest, it would be less than 25%. Then how much is normal PaO2? Upper limit is 100, everybody knows, but lower limit is 60 millimeter. So in mild asthma, the PaO2 value will always be more than 60 millimeters of mercury. But in severe attacks, you will notice that PaO values will be beginning to reduce. So oxygen saturation or SpO2 most of the time would be less than, like instead of saying 60, sometimes you may not have a ABG machine. So if you're having a pulse oximeter and the pulse oximeter in an asthmatic is giving me a SpO2 value of less than 90, then these values of 90 are usually seen. Obviously, it would be even lower in imminent respiratory arrest, but the message is like, suppose if I do not have a ABG machine available and I'm using a pulse ox, then values less than 90 is always a cause of concern. So if you compare the data here, if you compare the data, you can see the deterioration. Earlier, he was able to speak a full sentence and he could lie down. Now he's not able to lie down. And sometimes in the I'll show you a table also which will mention about pulsus paradoxus. That is, traditionally we read about pulsus paradoxus with respect to a patient who's having cardiac tamponade. We read about pulsus paradoxus in constrictive pericarditis. Pulsus paradoxus can be described even in imminent respiratory arrest and some cases of severe acute asthma as well. But I just try to explain to you that one of the best ways is that anybody who's having an asthma attack would be breathing very hard. His accessory muscles of respiration will be working very, very fast. But when you look at your patient, what you should look for is ability to communicate with you. You're going to check out his body position. You will listen to the rhonchi intensity and compare with whatever was the previous notes. And if you have a pulse oximeter ABG report, or if you have access to FEV1 at that point of time, that would let you know how is your patient responding. If it is a mild attack, never a cause of concern. All you need to give to the patient is ICS, inhaled corticosteroids with LABA, and the attacks will be responding. But in severe attack, you will have to admit the patient and give IV steroids as well. Plus nebulization with salbutamol would be required. And in case it is imminent respiratory arrest, then in those circumstances, we might even have to intubate the patient and manage accordingly. In this table, as you can see, the table is from current medical diagnosis and treatment. Is mentioned pointers like even checking out the pulse rate. Like you are noticing that if he's going into severe, if he's going into imminent respiratory arrest, if he's deteriorating from severe asthma towards imminent respiratory arrest, there's even a development of bradycardia. And then pulsus paradoxus can usually be present in severe acute asthma, and later part it might even disappear. The reason for this pulsus paradoxus disappearing in the later part is that respiratory muscle fatigue that is coming up. So a lot of this data that is given in this table, I have tried to simplify it and explain to you. The main point is when you talk to an asthmatic, if he can talk to you, that means he's okay. But if he's talking in words, if he's talking in monosyllables, it's always a cause of concern. Plus obviously look at the accessory parameters and you can grade and decide management. For mild to moderate attacks, most of the time the attack will respond to the current medication, whatever he's using. You just need to increase the dose of medication. But for severe acute asthma, hospitalization with nebulization is to be used, and that should always be oxygen-driven nebulization. If it is imminent respiratory arrest, we might even have to use magnesium sulfate. Yes, guys, in imminent respiratory arrest, while he's progressing from severe to this, even magnesium sulfate, the same drug that we read in eclampsia, in the drug part it will come up, but magnesium sulfate may even be used. Coming to the management part, for a mild to moderate asthma attack, we recommend usage of beta-2 agonists, that is formoterol and inhaled corticosteroids. And here your query would be, why can't we use a SABA? Then I would just like to say that yes, we can be using a SABA. But as I've explained to you that the recent guidelines discourage the use of a SABA alone. So he says that person who's using SABA alone would be having higher chances of development of death because airway inflammation is not being taken care of. So you should be using inhaled corticosteroids. And anyway, you're aware that formoterol is a LABA with rapid onset. So because of the advantage that it will have a rapid onset, it is giving a distinct advantage over a SABA, because SABA will act for only 4 to 6 hours and formoterol will act for 12 hours. So because my objective is good symptom control, so he says formoterol, which will give cover for 12 hours with inhaled corticosteroids, are recommended if it is mild to moderate. But if a person needs to be shifted to urgent care, because this treatment would be given on 1 hourly basis and it will show a visible improvement, or it will contribute to a substantial improvement in the condition of a patient, that would be visible to the patient himself, or like in case of a child, visible to the mother as well. But in case the child is becoming drowsy, or the patient is himself feeling that the tightness in the chest has increased, then he needs to come to the hospital. And that is where we will be starting nebulization with salbutamol. So what I want to bring to your attention is mainly the fact that SABA alone is discouraged as a standalone management, but it can be used as a rescue agent in an emergency management. Yep, we can be using salbutamol. And this should always be oxygen-driven nebulization, because you see on the back side of the nebulization chamber, there is an inlet, and most of the time we are just giving air-driven nebulization. Plain air-driven nebulization can cause worsening of an asthma attack. We should always be going in for oxygen-driven nebulization, air-driven nebulization. In fact, this is itself a question of yesteryears, that if air-driven nebulization is given, then it can contribute to worsening of the ventilation perfusion imbalance, and the oxygen saturation of the patient will worsen. I repeat the statement once again, because lots of time in our hospitals also, no, because they might be limited ports available to connect oxygen. We might be connecting oxygen from a cylinder to the nebulization chamber, and we might be giving cold chilled oxygen via nebulization chamber to the patient, which will worsen the bronchospasm. So air driven nebulization as well as plain oxygen which is not humidified is not recommended. They contribute both to development of ventilation perfusion mismatch. The summary is that we should be using oxygen driven nebulization, which should be properly humidified. Cold air, as it triggers, asthmatics have airway hyperreactivity, so the bronchospasm tends to get provoked in those circumstances. Then all cases who are admitted to urgent care should be given a single shot of hydrocortisone. Well, this is not an endocrine emergency, so why do we give hydrocortisone? Because it potentiates the effect of bronchodilators, and overall I can say from the pharmacology perspective that inhibits phospholipase A2, and this phospholipase A2 is responsible for generation of those mediators behind development of bronchospasm, that is leukotriene B4, C4. So we need to put a brakes on the synthesis as well. Then anticholinergics, that would be ipratropium bromide, can be given along with nebulization. You can notice that earlier we were giving 1 hour nebulization. In the emergency, we might be giving nebulization every 20 minutes as well. So one, the frequency with nebulization is increasing. Second, we are using a rescue agent like salbutamol. Now here your query would be, can we not use formoterol, if at this point? Yes, I can use it if it is available. But the point which I wanted to make to you, and I've been repeating all through this video, is that alone SABA usage is not recommended. It should be LABA, which is with rapid onset, and inhaled corticosteroid to suppress the airway inflammation. Then like in COPD, I've talked about tiotropium. Here I'm talking about ipratropium bromide. The only problem with ipratropium is that it has a slow onset of action. So initial management will be with beta-2 agonist, and then anticholinergics can be added. Then what is the mechanism of action of magnesium sulfate? Traditionally, we read about magnesium sulfate with respect to eclampsia. Well, guys, magnesium is an antagonist of intracellular calcium. Listen to my words carefully. I'm not saying magnesium is an antagonist in the blood to that circulating calcium. I'm talking about magnesium is an antagonist to the action of intracellular calcium. And you're aware that intracellular calcium is responsible for muscle contraction. So if I'm gonna give a molecule that will antagonize the action of intracellular calcium, that then bronchoconstriction will not be able to occur. Whatever has happened has occurred, but at least the worsening of bronchoconstriction will not occur. So we are trying to prevent this patient to going into a imminent respiratory arrest. Over and above this, they've also used NIPPV, that is non-invasive positive pressure ventilation, non-invasive ventilation. NI non-invasive ventilation is also has been discussed with COPD exacerbation and even in acute pulmonary edema. Along with that, even helium oxygen mixture inhalation has been recommended so as to contribute to decreased chances of this patient requiring mechanical ventilation, because their airways are constricted. So ventilating these patients will always be a challenge, and our objective is to prevent further deterioration with usage of what is called as reliever and controller medication. The objective is prevention, and for prevention, again, if he says how do you prevent an attack of asthma, then in simple words, to prevent an asthma attack, I should be using in my patient inhaled corticosteroid. Inhaled corticosteroid can be budesonide, beclomethasone. There are so many steroids which are available, and along with that, we should be using a LABA. That LABA would be a one with a rapid onset, and the dosage for prevention will obviously be lesser as compared to the dosage that would be used with respect to either an acute exacerbation or with respect to nebulization part that I'm talking about. I repeat that once again, guys. For prevention of asthma as well as acute management of asthma, it is ICS with formoterol. The dosages will vary. I will upgrade the dosage of steroids. I'll upgrade the frequency with which I'm giving formoterol. Earlier, it might be required only once a day, but now because the attack has come, I will increase the amount of inhaled corticosteroids and increase the number of times formoterol would be given. That would be like twice a day. The meaning of the word reliever is, I mean, what do you mean by reliever medication is that it will target smooth muscles. So it will cause an immediate improvement in the airflow entry into the lungs of this patient, because it's going to cause a bronchodilation. It will relieve the spasm of the airways. So formoterol is a reliever. As compared to controller, what will the controller target? It will target the inflammation in the airways, which I've explained is of two varieties. That would be either type 2 or non-type 2. Now, what is the goal of asthma therapy? The basic goal of asthma therapy is to maintain normal daily activity. And what I mean by normal daily activity is that the person is able to wake up on time, is able to go to his work, and he's able to sleep properly at night. The targets at the moment are that I need to reduce the frequency of symptoms of the chest tightness and shortness of breath to less than 2 times per week. And if I'm writing 2 times per week symptom frequency, then reliever usage. Reliever, as I explained to you, was targeting the smooth muscle. So for formoterol and ICS requirement should also be less than 2 times per week. So you just need to remember 2 times per week, 2 times per week for two things. That is for decreasing the symptom frequency as well as for relieving symptoms. What do you require a reliever? As far as nighttime awakening is concerned, here the denominator is not 2 per week. Here we are little more relaxed. In fact, it is less than 2 per month. So just remember that data for goals of asthma therapy, that reduce symptom frequency to that we are taking on a weekly basis. And when it comes to nighttime awakening, it would be less than 2 times per month, no more than one exacerbation per year. For that exacerbation, sometimes, sometimes due to pollution, due to smog, especially in October, November in North India, there's a lot of smog because of these crops, which are burned in a couple of states. There's a lot of, in the morning hours when you wake up, it's all gray skies. So that's when mostly asthmatics will have more frequency of attacks and they'll have more shortness of breath. And at that point of time, we might have to sometimes resort to usage of oral glucocorticoids as well, if inhaled corticosteroids are not turning out to be sufficient. And as I said, we need to have, or we want to ensure normal daily activity. Now, how do we achieve that? There are multiple ways for that. One is obviously drugs, but over and above drugs, we need to do some mitigation. Mitigation would mean that we need to decrease the exposure to allergens, whichever way it is possible, whether it is decreasing the exposure to allergen by using a mask, or advising a person not to go for a morning walk in early morning hours, especially in the winter months in our country, or it could be avoiding exposure to pollen grains. So, I mean, because sometimes attacks could be, especially in the spring season when the flowers would be blooming, and that's when asthma attacks would be coming. Then is allergen immunotherapy. This is recommended especially in those patients who are having concomitant allergic rhinitis and are also having nasal polyps. And then, as far as the role of vaccines is concerned, that is understandable. All asthmatics should be properly vaccinated. That is because already they're having a lung disease, and if they have taken pneumococcal vaccine, then they would not end up with unfortunate pneumonia. I mean, the recovery process in an asthmatic patient whenever he has any lung infection will be slower as compared to somebody who does not have a lung disease. So which are the three vaccines that an asthmatic should be always given? That would be a seasonal influenza vaccine, the nasal vaccine I'm talking about. Then COVID-19, I mean, there are no fresh requirement of COVID-19 vaccine, but I mean, person should have taken the standard Covaxin or Covishield, whichever was being given by the government at that point of time. You should be vaccinated. Though currently, I mean, the antibody titers would have decreased. There are no fresh guidelines for re-administration of COVID-19 vaccines, but yeah, person should have received the primary dosage that was recommended by the government for COVID-19. Now, as far as the bronchodilators are concerned, we have beta 2 agonists available. Well, how do they act? The mechanism of action would be that they'll activate this adenyl cyclase. This will contribute to increase in cyclic AMP levels, and cyclic AMP then contributes to development of bronchodilation. And then we can also study what are the drugs which are available here. We'll be having SABA, LABA, and then we'll be having ultra LABA, that is ultra long acting beta 2 agonist as well. There are a couple of side effects that would also come up. SABA, whenever you are giving salbutamol, the onset of salbutamol will come up as early as within 4 to 5 minutes or 4 to 6 minutes. So this is one of a rescue agent that you're using in severe acute asthma, as I explained. But the only limitation factor is that the total duration of action would be limited only for 4 to 6 hours, after which it will be back to square one, which is why it is nowadays recommended that we can use LABA. LABA, long-acting beta-2 agonist, can be working up to a total of 12 hours. The usual drugs which are available would be one by the name of salmeterol, and the second one would be formoterol. Most of the formulations nowadays which are available in the market would be those of formoterol with budecort. And whenever you're giving steroids to the patient, always tell them to do repeated mouth washing after every usage. That is to minimize the chances of development of oral thrush. Formoterol is a LABA with a rapid onset, and then they can ask you about ultra LABAs as well. The next category to be remembered is ultra LABA, that is ultra long acting beta 2 agonist. The advantage of these molecules is that they'll be working for a good 24 hours. So as far as repeated frequency of drugs would not be recommended. IOV would be for each of the first alphabets of the three drugs that I'm going to teach you. Alphabet I would be for indacaterol. Then is O is for olodaterol, and the third molecule which will be acting for a good 24 hours is vilanterol. So let's just recap the data on this particular slide. We need to go in for migitation. We need to reduce the exposure to allergens. We need to decrease the exposure to molds, etc. in the house. Like lots of time I'll say that in Hindi, sealant in the house. So because there's growth of molds, that peculiar smell that comes with the sealant part and the molds which are growing inside in that atmosphere can again trigger an attack of asthma. We need to ensure that the person is vaccinated for his COVID-19 and the other vaccines that I've talked about. And for symptom control, we can be using SABA, LABA, and then ultra long acting beta 2 agonist, which would be working for good 24 hours. Let's now focus on the side effects of these beta 2 agonists. This would be repetition of your pharmacology, that if you have ever used these drugs in your patients, I mean, they'll come up with you these two complaints that would always be palpitations. That would be because beta 2 will mainly act on beta 2 but has an action on beta 1 as well. That is why the tachycardia and the palpitations part can come up. And in some patients or susceptible patients, there might even be a transitory increase in the blood pressure, that is hypertension. So tremors in the fingers, tachycardia, palpitations, hypertension are the usual side effects. From the exam perspective, however, what you would be expected to answer is hypokalemia. I would like to remind you at this particular juncture that even while treating Hyperkalemia, we have talked about salbutamol nebulization. I mean, salbutamol also tends to send potassium inside the cells and helps in treating a dangerous hyperkalemia situation, like seen with renal failure, though traditionally we use insulin drip in that case as well. And then an important side effect which is currently on the radar is type B lactic acidosis. The previous examples of type B lactic acidosis are like diabetes mellitus or fenformin, metformin. Those are the times when I've talked about type B lactic acidosis. Today, your vocabulary has been expanded with even beta 2 agonists contributing to development of this side effect. And then I'll just repeat that once again. Clinical studies have shown increased mortality with the alone SABA usage. He says that alone SABA usage, basically repeated SABA usage, will most of the time even result in development of tachyphylaxis and the drug will stop working. If the drug is not working, then person's chances of mortality will increase. And don't be under impression that only severe acute asthma person can die. Even mild asthma patient can have a sudden deterioration, and thereby it is important that we give them a combination of controller and reliever medication, especially if we are going to target the inflammation part, which is the root of this evil. We'll be able to reduce the mortality which is caused. Then as far as anticholinergics are concerned, the logic is simple that bronchospasm is via smooth muscles. So if I'm going to use ipratropium bromide in my patient, though there would be side effects like dry mouth, there can be even possibility of constipation, but yeah, bearing a few tolerable side effects, I would say anticholinergics are a welcome addition. As far as theophylline is concerned, now it is rarely used. In the older editions of Harrison, for severe asthma, they always used to mention about IV aminophylline. But you will notice that now there is no mention of any aminophylline and even theophylline regularly because of the side effects which are associated with the usage of this drug. Even theophylline will act by increasing the value of cyclic AMP. It will act by inhibiting phosphodiesterase enzyme, increase cyclic AMP. Increase of cyclic AMP is a universal step that causes bronchodilation and causes release of symptoms, but is rarely used nowadays. Though in government hospital settings, you might be regularly writing theophylline to your patients, but he says that these are not recommended to be used on routine basis and neither in exacerbations because of the toxicity profile, and we should mainly focus our energies on giving moderate to high or increasing the dosage of inhaled corticosteroids and controlling the lung inflammation. The information on this slide for inhaled corticosteroids is what I've already explained to you, but they're mentioned and line to line from Harrison. So this is a first line therapy that can be question language. First line therapy for persistent asthma. Your answer should be given as ICS with LABA. They've been documented to lower mortality. Then rinse mouth with water after every usage. That's because once the drug is deposited, our main objective is to decrease the incidence of chances of development of oral candidiasis or oral thrush. The technique of the patient obviously needs to be checked. Every time we will tell the patient, to shake well before use, check out how many dosages are present in the MDI, that is meter dose inhaler. And then once he has used that MDI, which is having a combination of ICS with LABA, then we'll advise him to rinse his mouth to decrease chances of oral candidiasis. Then on concurrent or regular usage, we might even have to give prophylaxis for pneumocystis jirovecii. This data that I'm telling you, however, is valid for oral glucocorticoids. If a patient is on prednisolone and the dose of prednisolone that you're giving to the case is 20 milligram on a daily basis, a steroid should always be given on once a day daily dose. The advantage of giving a morning single dosage is to decrease the chances of Cushing syndrome. Because if we give steroids in divided dosages, it will increase the chances of development of Cushing syndrome and other side effects of steroids. The message at the moment is any asthmatic on oral glucocorticoids where the dosage of prednisolone exceeds more than 20 milligram per day, we should also be giving a prophylaxis for pneumocystis jirovecii. And he can also ask you what is the normal drug, which is, how do you go in for prophylaxis on pneumocystis jirovecii? So even in HIV video, we have discussed it. You are aware from your other pharmacology classes as well. That would be cotrimoxazole. Then there is a role of leukotriene modifiers as well, because leukotrienes are again important cytokines that play an important role. So there are two drugs which are commonly used, that is montelukast and zafirlukast, and even we have a mast cell stabilizer available. I mean, chromoglycate sodium, if it has to be used, it usually has to be started 1 month before the attack begins. Like sometimes asthmatics, they tend to have attack in the spring season. So I'll tell an asthmatic to start taking it 1 month before. That would be available as a powder preparation, which has to be taken at least 1 month before to produce some therapeutic benefit. Advantage of Montelukast is that it will help in allergic rhinitis component, which could be coexisting. And then, especially in children, Montelukast is advisable because you see, inhaled corticosteroids can cause growth retardation. You see, the normal impression is only oral glucocorticoids. OC stands for oral glucocorticoids. Uh, Traditional impression is that only oral steroids will cause growth retardation. That is okay, but even inhaled corticosteroids in children have been shown to cause growth retardation. Because of that, usually prolonged administration of inhaled corticosteroids would not be recommended. And once the attacks are controlled, we can switch over to leukotriene modifiers like Montelukast. Montelukast has a side effect which has recently been highlighted by the Federal Drug Authority, and this is a cause of concern. That would be suicidal ideation. I'll just say the benefit and the disadvantage of Montelukast. One benefit is it will be working even in allergic rhinitis component. The second advantage of Montelukast is that it will be preferred to be used in children. I'm not writing it because that's a pediatric data, but I'm just saying that because children, at the growth spurt part, if you're giving inhaled corticosteroids for long duration, the final height of the child will be lesser. So in pediatrics, they always teach us that wherever possible, if the attacks are not very frequent, you can switch over from inhaled corticosteroids to leukotriene modifiers, because steroids, even inhaled corticosteroids, can contribute to development of growth suppression. For sodium chromoglycate, I would just like to say that once again that they take a long time to act, so should be started well in advance so that you can manage your patients accordingly. Let us now focus on mechanism of action of omalizumab, and this would be a repetition for you guys from pharmacology as well, but more you study, better you have higher chances of retention. So omalizumab, the main mechanism is that it will prevent binding of immunoglobulin E to the mast cells, because you know that once immunoglobulin E will bind to the mast cells and basophils, it's going to cause release of interleukin 4 and interleukin 5 as well as interleukin 13. So here we are trying to prevent the release of those cytokines by preventing the binding of immunoglobulin to the inflammatory cells. So therefore he will ask you what is the indication. I mean, when would you be starting omalizumab to in your asthmatic patient? Your answer would be that if an asthmatic is having his IgE levels to be more than 30 international units per ml plus, there are two things here. One is that immunoglobulin is elevated, obviously, because we are talking about an anti-immunoglobulin E molecule, so IgE has to be elevated. Plus, the additional fact is that your patient who's having asthma is still symptomatic while he is on. Now listen to the words. M means moderate dose of steroids, H means high dose of steroids. So my patient is already on inhaled corticosteroids moderate to high dose plus LABA but is symptomatic. I'll repeat the information once again. I have said this is an anti-immunoglobulin E molecule. So there are two things to be remembered, which is that person's IgE should be elevated, not more than 1000. Earlier I was teaching you IgE values more than 1000 and that brownish sputum plugs to be present, central bronchiectasis, that was APPA. Here I have not said those obscenely high values. I've said IgE more than 30 international, patient is symptomatic. Okay, I'm going to start him on omalizumab. In contrast, when it comes to mepolizumab or reslizumab, these molecules are anti-interleukin 5 molecules. But when it comes to benralizumab, your answer would be this will be basically blocking the receptor of interleukin 5. So there's a difference in the mechanism of action of the top two drugs versus the drug at the bottom. Mepolizumab, reslizumab, the mechanism is anti-interleukin 5, whereas benralizumab will basically bind to the interleukin 5 receptor, block it, and therefore interleukin 5 will not be able to act. Now let's look at the indication. When would you be prescribing mepolizumab to your patient? Your case is he's an asthmatic, the patient is symptomatic while he is on moderate to high dose inhaled corticosteroids and LABA. Now when I write it, the query of most people is, sir, you told the same thing even for omalizumab, so is the indication for the two the same? No, here I'm not saying that immunoglobulin E is elevated. What I'm saying is the patient is symptomatic on moderate to high dose inhaled corticosteroid is on LABA, and along with this I'm saying he's had at least two exacerbations in recent couple of months, and each of these two exacerbations were requiring oral glucocorticoids, because every time you are giving oral glucocorticoids, OC means oral corticosteroids being given, every time you're giving steroids to an asthmatic, you are increasing the incidence of side effects, conversion of pre-diabetes to diabetes. You are increasing the risk of, infections. You are increasing the risk of development of Cushingoid features. You are increasing the chances of development of osteoporosis. And considering the fact that oral glucocorticoids can even contribute to avascular necrosis of the hip joint, and we saw that at COVID time, no, we were giving steroids, hypertensive ones, and suddenly now you are having much more higher number of people requiring hip joint transplantation because of high dosage of steroids that were required. So the indications between the two is slightly different. In one of them, it is patient symptomatic in spite on the common thing is patient is symptomatic on moderate to high dose inhaled corticosteroids, but the difference is that on the left hand side, because it is anti-immunoglobulin E molecule, so IgE is elevated. On the right hand side he required steroids for his exacerbation. Then coming to dupilumab, I would like to remind you that the receptor for interleukin 4 and interleukin 13 is common. The receptor for both interleukin 4 as well as interleukin 13 is common, that is interleukin 4 receptor alpha. And dupilumab, what it does, it will block to this receptor, and once it will bind to this receptor, then it will block the signaling process, and as a result of it, the substantial airway inflammation can be neutralized. Let's do a quick recap here. Anti-immunoglobulin E is omalizumab. You know that from pharmacology. Mepolizumab is gonna neutralize interleukin 5 directly by binding to it, whereas benralizumab is binding to the receptor of interleukin 5. And when it comes to dupilumab, which is usually the one that is asked, your answer would be it will bind to the common receptor and block the signaling that occurs subsequently due to release of interleukin 4 and interleukin 13. They're gonna bind to a common receptor. We're gonna bind to that receptor and prevent the cytokine induced airway inflammation. The next table that I'm going to teach you is from Harrison. You don't need to memorize it or cram it. Just listen to my information, which is that how do I prevent asthma from occurring? I will be telling my patient that I'm writing a puffer for you, that's a meter dose inhaler, and what will it be containing? It will be containing Budecort, and along with that it will be having formoterol. I'll tell him take it whenever you have an attack. Now, in spite of the fact that he is taking this whenever he's having an attack, still the attacks are persisting, then I'll tell him to take low dose inhaled corticosteroid on daily basis. If this alone is not working, I will be then switching to low dose inhaled corticosteroid with formoterol. The query at the mind of most people is you told the same thing even earlier. You see, if you're listening to me carefully, earlier I was saying when required, for this part I was saying take this medication of Budecort with formoterol when it is required, whenever you have an attack. But if you're having attacks on a regular basis and you can't sleep at night, then you have to take it daily. So that would be step 3. For step 4 and 5, nobody has any issues. From low dose, I'll upgrade to a medium dosage. From a medium or moderate dosage, I'll upgrade to a high dosage of steroid, and I will also add up LAMA, that would be ipratropium. But if I've tried everything, then I have two options available. Either I can use oral glucocorticoids. If person can't afford, I will have to use oral glucocorticoids, but if patient can afford, then I will have to select between these molecules. That can be omalizumab or mepolizumab or dupilumab, and the selection will be based on the values that I was explaining to you. Like if IgE is grossly elevated plus is having attacks with medium to moderate dose of inhaled corticosteroids with LABA, then I'll prefer using omalizumab injections, which need to be given 2 to 4 weekly. Though obviously these molecules are expensive and a lot of our poor patients are not able to afford them, so then we will have to use oral glucocorticoids. Next up is exercise-induced asthma and drug-induced asthma, and they're towards the end of this video, so I know you're bound to get restless, but we'll just practice them because they're important. If he says it's occasional exercise once in a while, then what I can advise him is the conventional data, that is inhaled corticosteroids with a LABA, which is having a rapid onset. Do not give salbutamol here. Patient might try to smart before you and act smart before you and say, what if I take salbutamol 5 minutes before exercise? The only thing is salbutamol will work for a few days. Then salbutamol causes tachyphylaxis, tolerance aa jata hai, so the drug will stop working. If he's gonna be doing a regular exercise, like let me say this is an army chap and every day in the morning he has to do a PT drill, and for years altogether, if he's taking inhaled corticosteroids, it will predispose him to the problem of oral thrush. And if he's an army person, he has to do exercise, then it's not possible to take a puff and then rinse mouth while he's out in the field, and they would not allow him to carry that puffer also. So in those circumstances, he says that if person is doing regular exercise, then montelukast can be used. For aspirin-induced asthma, the first approach is obviously to avoid the drug. That's the first approach. But if we cannot avoid the drug, then the second approach is desensitization. Like you are aware that we have desensitization for penicillin, we can also plan a desensitization for aspirin where the dosages would be introduced gradually in incremental amounts. And in case these are not working and still you need to give aspirin to the patient for cardiovascular reasons, then he says that you can be using molecules like mepolizumab, which was anti-interleukin 5, or we can be using dupilumab, which was working on that common receptor for interleukin 4 and interleukin 13. Next up is hypersensitivity pneumonitis, and this condition is alternatively also called as extrinsic allergic alveolitis. At this junction, I would like to state before you that the only thing common between asthma and hypersensitivity pneumonitis is the word allergy. Otherwise, both are fundamentally separate disorders because asthma is all about narrowing of the airways. Whereas at the moment, I'm not teaching you any narrowing, I'm teaching about inflammation in the alveoli, and that is why I'm using the term pneumonitis slash alveolitis. Even the class of antibodies here are different. In asthma, it was all about immunoglobulin E class of antibodies. Here I'm talking about immunoglobulin G. And the best example of this is farmer's lung. Now in farmer's lung, the question will say that this guy is a farmer by profession. He walks into barn. Barn is an area where they store grains, where they store hay, dried grass. And he will say that inhalation of what will cause this alveolitis and cause breathing difficulty within 4 to 8 hours of exposure. It would be inhalation of thermophilic actinomycetes. Then in the older editions of the book, we used to read about another fungus. The name was given as micropolyspora. But this time you will notice a different name written, that is Saccharopolyspora rectivirgula. So a bit of tongue twisting name, rectivirgula. That is anyway the subsequent name. The complete name is Saccharopolyspora rectivirgula. And well, this person is a farmer by profession. He's walking into area that's called as a barn, and barn is where they're gonna keep grains. They're gonna keep that hay. And I'm writing the word moldy hay to say that on the dried grass, it is that fungal spores that are being inhaled and are causing damage in the alveoli. Then we also read about bird fancier's lung. Well, bird fancier's lung should not be mixed up with psittacosis, because psittacosis is pneumonia which would be seen in a person exposed to birds. But at the moment, bird fancier's lung, I mean, psittacosis is a proper lung infection caused by chlamydia, but bird fancier lung would be mainly exposure to bird feathers, because they keep on shedding these feathers, and then exposure to droppings of the birds as well. We have already discussed that pigeon droppings would be having cryptococcus, and that can cause in immunocompromised patients cryptococcal meningitis. But today I'm saying that pigeon droppings and then bird feathers can contribute to a HP as well. That's called as bird fancier's lung. Then hot term lung would be caused when person is exposed to contaminated water. And in this patient's house, there is a lot of sealant also present. Sealant is a Hindi word basically. The English word would be mold on the ceiling. I mean, that greenish black thing that will grow, especially in rainy season. If the roof of the house is leaking, then there could be like a lot of sealant coming in and there would be growth of mold. So growth of mold on the ceiling can contribute to a person getting seriously ill and ending up with hypersensitivity pneumonitis. Well, in this case, the exposure would be to MAI, that is Mycobacterium avium intracellular. And while I'm writing it, I just want to remind you that the last time I've spoken about Mycobacterium avium intracellular is in an immunocompromised patient, no AIDS positive patient, CD4 count more than 50 is where we read about MAI. But today I'm teaching you that the person is healthy, no AIDS exposure, but this guy is being exposed to contaminated water with respect to hot term lung or Cladosporidium, that's another fungus. And then next guy is a woodworker by profession, and he is getting exposed to Alternaria species. In fact, here they also mention regarding a bacteria by the name of Bacillus subtilis. Though I'm not mentioning the bacteria name, I'm just saying verbally at the moment. So there's a huge list given in Harrison with respect to hypersensitive pneumonitis, out of which the one which is most important one to be remembered is farmer's lung. One of the most important thing which is useful for diagnosis of this condition is called as clinical prediction rule. Clinical prediction rule will simply mean that we need to demonstrate, okay, the person is exposed to a particular antigen. The moment we take him out of this atmosphere, the symptoms of this guy will totally disappear. Plus, there would be antibodies present. The class of antibodies I told you were immunoglobulin G. Symptoms will start within 4 to 8 hours. In asthma, symptoms will develop even more faster. If an asthmatic is exposed to allergen, symptoms will come within 1 hour only, or even lesser than that. Here, symptoms usually are seen between 4 to 8 hours, and then we also tend to have, because this is an immunologically mediated disorder, we can be having low grade fever, we can be having malaise present in these patients, and because this is an allergic condition, ideally for management, there's no drug or choice for management of this. Ideally, for hypersensitivity pneumonitis, the person should stop working in that occupation. But it is not practically possible solution. So maximum we can use the steroids, but do not answer bronchoalveolar lavage or pulmonary function testing, or do not answer any of those anti-interleukin 5, interleukin 4 molecules that we were discussing earlier for management of this condition. Why hypersensitive pneumonitis have just brushed upon, though I would suggest you to read about this topic from pathology as well, is to mainly sensitize you to the target of the lung which is getting affected, and that is the alveoli, and the class of antibody in this case is also different. To finish this slide, I would like to mention regarding Churg-Strauss condition. Churg-Strauss syndrome, we tend to read lots of time. Most of the time, the questions that we read for Churg-Strauss syndrome will now be saying EGPA, that is eosinophilic granulomatosis with polyangiitis, just like the word vaginous granulomatosis is not used, and we use GPA, granulomatosis with polyangiitis. We are teaching eosinophilic granulomatosis with polyangiitis. The reason I'm teaching you this is mainly because in asthma also eosinophil count is elevated, and in this condition also the initial presentation is that of asthma only. These patients will also be having peripheral eosinophilia. As much as 75% of white blood cells can be eosinophils only. Lung infiltrates would also be present. So initially, asthma is the standard presentation. But later on, the nerves would get involved. So in bronchial asthma, you don't have nerves getting involved. If you get a question which is having asthma, and along with asthma, he also starts talking about mononeuritis multiplex. Again, mononeuritis multiplex, where do you read? You read it in polyarthritis nodosa. You read it in leprosy. Common conditions where you read mononeuritis multiplex is polyarthritis nodosa or in leprosy. But one more we are studying, that is Churg-Strauss syndrome, plus heart can be involved. That would be myocarditis. Then there can be GI involvement that can cause diarrhea, and eosinophilic gastroenteritis, and even kidneys can be involved, that is glomerulonephritis. So if you get a question which is having asthma plus these features that I've just told you, that is nerve involvement, cardiac involvement, eosinophilic gastroenteritis, glomerulonephritis, and standard features of vasculitis, which will contribute to fever and development of weight loss. Any vasculitis, usually has very severe constitutional symptoms. So if you add all of this together, asthma plus the manifestations that I have said, then you have to think in terms of EGPA. And in this question, he might help you by writing regarding P ANCA as well. It may or may not be present, but the point is P ANCA is usually seen in microscopic polyangiitis and can also be seen with Churg-Strauss syndrome. The main reason why I've explained this disorder is mainly to remind you that if a question of asthma talks about these accessory findings, then Churg-Strauss has to be taken into consideration. And if he always talks about asthmatic with brownish sputum plugs, then you always have to think in terms of ABPA, that is allergic bronchopulmonary aspergilloma. Though aspergillus as a topic is even mentioned in infections part, I've given hints here. Usually this question will also mention about grossly elevated values of immunoglobulin E. It will at the same time also mention this very classical radiology term, that is central bronchiectasis. So these are a couple of terminologies that I would like you to remember for the topic of bronchial asthma. I've incorporated the latest updates in the text from the textbook as well, and I've tried to incorporate a couple of other miscellaneous disorders which can be asked to you in the exam because of similar terminology like hypersensitivity, allergy terminology makes us think that okay, HP looks like asthma, but that is not the case. So I know it took a while to finish this, but hats off to your dedication that if you read till the end of this video, you are right on the track to the pathway to glory. And as I say always, keep hammering, keep the pressure on, keep on learning new things every day. and you'll become wiser. And as I say, the most important thing, that's the second information, I would say second most important information after everything that we've learned: knowledge is power. When you apply it, it just amplifies and makes you a better person. Thank you.